Sutures are an immovable joint found between adjacent flat bones. Cranial sutures specifically are an immovable joint found between the bones that make up the cranium. No action or movement takes place at this joint. This is for obvious reasons. We wouldn't want the bones of our cranium to be moving because then potentially they would push up against our brain, causing damage. If we were to look in on these irregular edges here, they are able to interlock, and then there are fibrous connective tissue holding the two bones together in this immovable joint. If we looked at a cross-section of that bone, it would travel fully through that flat bone such that there's a connection through the complete thickness of the bone. This provides strength to the skull, as previously mentioned. So what are some of the major cranial sutures that we should know the name of? We want to locate the sagittal, coronal, and lambdoidal cranial sutures. To look at a different picture of the skull, to show the different cranial bones in different colors, let's zoom in on that image and then include the names of the cranial and some of the facial bones that we've looked at in the previous portion of this unit. The coronal suture is found here, between the frontal bone and the parietal bones. The lambdoidal suture is found here, between the parietal bones and the occipital bone of the cranium. And finally, the sagittal suture is found on the top of the skull, running between the two parietal bones that are on the right and left-hand side of the cranium. Recall earlier in the course we talked about the sagittal plane, dividing the body into equal right and left parts. The sagittal suture runs down that sagittal plane between the two parietal bones of the skull. Here we're looking at a fully formed adult skull. However, at birth, the skull has not fully developed and looks something like this. The cranium is separated by fibrous membranes called fontanelles. Here we have the anterior fontanelle found at the front of the cranium, and here we have the posterior fontanelle found at the back of the cranium. The purpose of the fontanelles are to allow for some movement during the birth of a child. The skull can change shape to some extent, allowing it to ease its way through the birth canal. When the baby is first born, this is an area where sometimes even pulsations can be felt because it is not fully solid bone at that time. Therefore, it facilitates certain diagnostic assessments that you might make of the offspring. On top of that, it's an area of the offspring that needs to be protected until the fontanelles have disappeared and bone has fully formed. Let's look at those fontanelles from a different angle. Here's a superior view of the cranium of the baby. We can see here, there is the anterior fontanelle and the posterior fontanelle that we were just discussing. The anterior fontanelle is diamond-shaped. It's the largest of the two fontanelles and usually closes when the baby is around 18 months to 2 years old. The posterior fontanelle is triangular-shaped more between the occipital bone and the parietal bones, and it usually closes before the baby turns 1 year old. Moving down from the skull, we can describe the basic organization of the vertebral column. The vertebral column extends from the skull to the pelvis. It's made up of multiple bony parts called vertebrae. In between the vertebrae are intervertebral discs, made up of fibrocartilage. They're also connected via ligaments, forming joints, articulations between the bones. And the function of the vertebral column is to support the head and trunk, and also to protect the spinal cord. There are several regions here within the vertebral column, as shown by the different colors of the vertebrae. The first, closer to the head, are the cervical vertebrae, of which there are 7. The term cervical refers to the region of the neck. The top cervical vertebrae has its own name, the atlas. It supports and balances the head, and it articulates directly with the occipital bone that we saw in the cranium. The second cervical vertebrae is the axis. It's got a process on it that projects upwards and lies within the ring of the atlas. As we turn our heads, the atlas pivots around that process, and we'll take a closer look at that in a little bit. The next 12 vertebrae are the thoracic vertebrae. They increase in size as we move down from the cervical vertebrae. That increase in size is because as we move down, each vertebrae is bearing more and more weight due to more of our body being above it. Each of the vertebrae has a long pointed spinous process with facets then that articulate with the corresponding ribs. Notice that we have 12 thoracic vertebrae and we have 12 sets of ribs as well. As our ribs wrap around the back, they attach to the thoracic vertebrae. The next 5 vertebrae are the lumbar vertebrae. They are sort of the small of your back, down in your lower back. Sometimes you get special chairs for lumbar support. This is the region that we're talking about in terms of supporting your back. There are 5 vertebrae that again continue to get larger and larger because they are supporting even more weight than the thoracic vertebrae. Next we get to the sacrum, which is a triangular structure made up of 5 fused vertebrae. So they're not the joints as we see above with the fibrocartilage between them, but these vertebrae have fused together forming the sacrum. The dorsal sacral foramina are the little holes that you see in the sacrum there that allow for the passageways of nerves and blood vessels that are running down the body to go to the lower part of the body and the legs. And then finally we have the coccyx. This is the termination of the vertebral column. It's made up of 4 fused vertebrae, and it's attached to the sacrum by ligaments. Let's describe the curves of the vertebral column and explain how secondary curves develop. To do that, let's look at the vertebral column from a different angle. So here is a right lateral view of the vertebral column. We have a number of curvatures here that give the vertebral column sort of an S-shaped structure. We have the cervical curvature, which is a concave curvature. We have the thoracic curvature, which is a convex curvature. And then the lumbar curvature, again concave, and the sacral curvature, which is convex. This concave-convex structure works together to prevent shock to the head when we walk or we run. Of these curves, the thoracic and sacral curves are considered primary curvatures. The cervical and lumbar curves are called secondary curvatures, and this is because how we develop from offspring. So to look at that, when we are first born, we have this kind of curvature to our vertebral column. It is completely convex, and that matches the thoracic and the sacrum curvature. And that's why it's considered the primary curvature, because it is the first to appear that we have right since birth. And then the secondary curvature, the cervical curvature and the lumbar curvature that are convex, occur later on. The cervical curvature occurs when a baby first starts to lift their head. As you can see here, the rest of the curvature remains the same, but as the baby is lifting its head, then the cervical curvature starts to become convex. And then when the baby starts to walk, you can imagine, as is shown on the right-hand side here of the vertebrae, that as we bring our legs underneath us and we stand up straight, the lumbar curvature starts to form. Let's go back to this original picture so that we can describe a typical vertebrae. Removing those 2 items, we can take a look at cervical vertebrae. A cervical vertebrae looks something like this. The main things to point to here are the body of the vertebrae. It's disc-like. It's the weight-bearing portion where the most bone is found. It faces anterior. And when we stack all of the vertebrae together, those bodies are all on top of each other, and it's a longitudinal row that supports the weight of the head and the trunk, ultimately, when they're all stacked. At the back of the vertebrae, we have the spinous process. It's a single projection arising from the posterior aspect of the fused lamina shown to the side. We then have transverse processes. Transverse processes are processes that stick out along the transverse plane. In the cervical vertebrae, they're not very large here, but you can see that there's a transverse foramen, which is referring to a hole within the transverse process. The vertebral foramen then is the hole that is formed by the body at the anterior portion, the lamina and the spinous process, the lateral and posterior portion. And that vertebral foramen is the hole that the spinal cord actually runs down. To take a lateral view of that same cervical vertebrae, we can see here that we have the body, we have the transverse process, sticking off to the side of the body in the transverse plane, and then we have the spinous process sticking off to the posterior side of the vertebrae. If we were to then go down and look at thoracic vertebrae, here is the superior view and then the lateral view of the 10th vertebrae within the thoracic vertebrae. And then look at the lumbar vertebrae. This is the 3rd vertebrae, the superior view on the left and the lateral view on the right. We could see that they all have that same basic structure with a body, the lamina going back to the spinous process, the transverse processes sticking off the side, and then the vertebral foramen that the spinal cord actually runs down through being formed because the body, the lamina, and then the spinous process surround that hole that the spinal cord runs down. So even though these don't all look exactly the same, a typical vertebrae has those components that we just discussed. To look at some vertebrae that look slightly different, let's look at the atlas and the axis. You'll notice that some of the components are the same, but they look quite different from the other vertebrae that we were just looking at. One area in particular that I'd like to point out is the dens of the axis. It sticks up from the axis, which is not anything we saw in any other vertebrae. Remember earlier we said that the atlas and the axis sit on each other, and that the dens, shown here, sticks up and the atlas actually rotates around it in order for us to turn our head. I mentioned we would come back to that because it is an important component in terms of the overall movement of our head. This is also a pretty good image to show where the two bones actually connect to each other. So to the right and left side of the dens between the two bones, you can see where there's actually a joint between the two bones. And as you move your neck, those portions of the bones would slide over each other and allow for movement. If we were to look at the overall vertebral column, a lot of those transverse processes and so on have these regions where they are joints between the different bones, allowing for some movement of our vertebral column. Let's move on to locate and describe the basic structure and explain the function of the intervertebral discs. In the image on the left here, you can see that beyond the vertebral discs, there's a little gray area on the right-hand side of the vertebrae. These are the joints that I was mentioning where the transverse processes and so on would attach to each other and allow for some movement of the vertebrae. However, that being said, the vertebrae have very little ability to move. And that's because we have, within the space running down the vertebral column, the vertebral foramen that we discussed earlier, we have the spine. And so we don't want a lot of movement because then we could potentially damage the spine. The vertebral discs allow for cushioning between the bodies of the vertebrae, but then they have a particular structure to allow for just slight movement so that no damage to the spinal cord occurs. If we were to cross-section the vertebral column in that area, we would see that the disc is actually made up of a couple different parts. We have the annulus fibrosus, which is on the outer portion of the fibrocartilage disc. And then in the middle, we have the nucleus pulposus. To take another look at that, in this case a superior view of it, around the outside we have the annulus fibrosus disc, and then we have in the middle the nucleus pulposus disc. Overall, this fibrocartilage allows for shock absorption and contains a large amount of water. It's a little bit spongy and compressible, but when we look at these two different parts, the nucleus pulposus of the disc is the spongier part that allows for a little more cushioning, whereas the annulus fibrosus of the disc is a ring of fibrocartilage which limits the expansion of the nucleus pulposus, keeping it in place. And so collectively, the structure of the disc gives the spine some flexibility as it flattens and bulges, allows for an increased range of motion, but then ultimately provides protection of the spinal cord. However, if you haven't noticed already, in the right-hand image here, we have a situation where damage has occurred. On the top left side of the annulus fibrosus of the disc, you can see that there's been a weakening of the annulus fibrosus. Some of the nucleus pulposus is bulging out, pushing up against one of our spinal nerves. This is the kind of damage that can occur when someone has some damage to the back due to an injury, or sometimes due to the weakening of these discs as we age and our water volume decreases and the disc starts to become less flexible. Moving down from the vertebral column, we can describe the structure of the pelvis. If we were to look at the pelvis a little bit closer here, it's made up of several parts. The first is the sacrum that we discussed in the vertebral column. On top of the sacrum, there's also the coccyx at the bottom of it that also makes up a part of the pelvis. Then we have a coxal bone. In fact, we have one here on the left side and then one here on the right side. They are attached posteriorly to the sacrum, and they are attached to each other anteriorly. So overall, the pelvis is composed of those different structures, the sacrum, the coccyx, and the two coxal bones. If we were to look at one coxal bone, it would look like this. In this picture, we're looking at a medial view of that coxal bone and a lateral view of that exact same coxal bone. As you can see, the coxal bone can be further divided into the ilium, the ischium, and the pubis. The ischium being on the posterior side and the pubis being on the anterior side. The ilium is the largest portion of the coxal bone. It flares outward and forms the prominence that we would call the hip bone. The outer margin of it at the top is called the iliac crest. We have the pubis. It joins together to form an immovable joint at the front of our pelvis called the pubis symphysis. And then the ischium is the lower portion of the coxal bone that supports the weight of the body when we sit. So those are the three basic portions of the coxal bone, but now let's locate and describe several other regions and portions that we should know. We'll start with the acetabulum. The acetabulum is a cup-shaped depression. All three bones, as you can see here, meet at this point, and the head of the femur articulates with the acetabulum. The head of the femur fits into that cup-shaped depression and then is connected to the pelvic bone via ligaments. We actually saw that joint earlier in this unit when we looked at the structure of ligaments. We also have the iliac crest. I mentioned this earlier. The iliac crest is the top of the ilium, that outer upper margin of our pelvis that forms the prominence that we would call the hip bone. Then we have the obturator foramen. This is an opening for blood vessels and nerves to pass down to the anterior thigh. The ischial tuberosity is a roughened area that takes the weight when we sit. On top of that, it's an attachment point for tendons and leg muscles. The ischial spine is superior to the tuberosities. It's an important obstetrical landmark. It represents the most narrow outlet of the pelvis through which the baby must pass during childbirth. Speaking of that, let's take a different view of the pelvis. Here we're looking at a superior view of the pelvis, looking down at it. Some things that we should point out that are important here is the pubic symphysis that I mentioned earlier, being the connection point between the two pubis bones of the two coxal bones. This is at the anterior portion of our pelvis, holding the two coxal bones together at the front. Then we have some measures here that are important in terms of the structure of the pelvis. We have the true pelvis, or the lesser pelvis, which is represented by this pink ring here that runs all the way around the pelvis. The true pelvis forms the boundary of another ring-like passage that we'll look at in a minute called the pelvic outlet. Then we have the false pelvis, or greater pelvis. It's bordered by muscle in the front and bone on the sides and the back. And then here are the ischial spines that we can see sort of stick into that area. Even though they're projecting off of the ischium, they narrow that opening within the pelvis. In terms of those openings in the pelvis, we can compare male and female pelvises. One item that I'd like to point out here is the sacral promontory. We've kind of seen that previously, but this is the portion of the sacrum that extends furthest into the pelvis, most anteriorly into the pelvis. Depending on its location, it would change the shape of the pelvic inlet that's outlined in blue here. That is an area that goes from the sacral promontory to the pubis and then the symphysis pubis. It basically forms the brim of the true pelvis that we saw earlier. But then the pelvic outlet runs between the ischial spine, the coccyx, and the symphysis pubis. This is where the digestive system and then the female reproductive tract pass through. And so this is important in terms of birthing. We can see here that in the female, the pelvic outlet and the pelvic inlet are both quite a bit larger than in the male. This is because if birthing a baby, the baby would need to pass through that pelvic outlet in order to be birthed. Therefore, we need the larger pelvic outlet within females. We can also see that the subpubic angle in a female is much wider than in a male. Again, this is because of that larger pelvic outlet within the pelvis.